So let's keep going. So we talked about neuromuscular junction. We talked about muscle. Let's talk about peripheral nerves. We'll talk about this relatively briefly, and then we'll keep moving on. But for me, I think of a few things when we talk about peripheral neuropathies or polyneuropathies. So there's a few types of, when you say neuropathy, there's a lot of different types. We're going to talk specifically about what's called a polyneuropathy, which is a widespread degeneration of your peripheral nerves, your nerves underneath the skin. So the first thing that my patients tell me about is a distal sensory loss. So they'll come in and say, you know, doc, my feet, they're starting to tingle, or I can't really feel my toes very well. When you examine them, you'll see a couple of sets of issues. One, you look at what I call large fiber neuropathic issues. So loss of vibration sensation and a loss of proprioception. We'll be talking about this stuff when you do your palm stuff as well. And then they may also experience a loss of pain and temperature, and that can be associated with your smaller unmyelinated fibers as well. Other things you'll probably see, so you'll see reduced reflexes. They may be completely absent if it's been long enough or bad enough of a neuropathy. And the other thing you'll see is a distal weakness that's usually, or a weakness that's usually distal predominant. So we talked about the feet starting first. If they have weakness, it usually starts there. And these symptoms start distally, like in the feet, and then creep and work their way up proximally. And so you'll have what we often call a stocking glove distribution, where the stocking part of it is that it starts in the feet, works its way up to about the knees, and when that happens, the hands start to join the party. And then things to be aware of, it affects multiple types of fibers. We talked about the sensory findings, the motor findings, and in some cases you'll see some autonomic features as well. So those can be a wide range of things. So they can be a little bit difficult to list, but you have to be aware of those things when you're interviewing your patients.
That's interesting, because I suppose at least some neuropathies are associated with advanced diabetic disease, diabetic neuropathy.
Yeah.
That's probably why those patients tend to get some foot ulcers and wounds, and they burn themselves and they don't even feel it.
Here, it's probably the most common cause of a polyneuropathy.
Wow.
And that's the thing that I typically look for the most when I'm thinking about a polyneuropathy.
Yeah.
In fact, my entire mom's side of the family has type 2 diabetes. So actually my uncle came, I saw him during a Thanksgiving dinner a couple years ago, and his doctor told him he had gout, and I said, how bad is your diabetes? It was, let's suffice to say, it was very bad. And so I told him, I think you might have diabetic polyneuropathy as opposed to gout.
Yeah.
And he had this sort of tingling pain sensation that I often do see in polyneuropathies.
Yeah. That's why you go to the some of the drugstores, and there is whole aisle of special socks and shoes and all those things for diabetic people to protect their skin and extremities.
Yeah.
I'm just bringing this up to give you a flavor of, how this actually translates to real life, from examples that we live all the time.
So I guess we could talk about what you can see if you have some of these issues happening pathologically. So even though muscle biopsy is done predominantly for myopathic diseases, sometimes the muscle is okay and there is a problem with the nerve, as we just discussed, and of course then the muscle will have some loss of the innervation and will show denervation changes. Please note that this happens only when the motor nerves are involved, that we can see changes in the muscle. Sensory neuropathies, we will not see changes in the muscle unless they also involve motor nerves. There are some diagrammatic changes here I think will be easier to go over. Here is your checkerboard pattern of type 1 and 2. It is thought that the fiber type is decided by the neuron that they innervate. And so type 1 and 2 doesn't matter which one is which. There are two types of fiber normally. And then let's say this neuron got injured somehow and the fibers lost their innervation. They're fine themselves, but because they're not getting stimulation, they now become atrophic.
But because of the pressure of the surrounding normal fibers, they acquire this angulated atrophic, sometimes triangular, peculiar shape rather than that rounded atrophy of the myopathy. After a while, the surrounding intact nerve fibers will take over these, let's say, orphan myofibers that have lost their innervation. And because fiber type is determined by the neuron type, then these fibers turn into that type of fiber. And now, instead of that checkerboard pattern, now you have whole group of fibers that are innervated by one neuron and another group by another. So this is called fiber type grouping. If this is a progressive process, let's say this neuron that acquired all these myofibers also got injured and died, and now all this entire fascicle pretty much that was innervated by that neuron becomes atrophic. So this is group atrophy. So these are the changes of acute denervation with angulated atrophic fibers, reinnervation by fiber type grouping, and chronic denervation by large group atrophy. Sometimes we also do nerve biopsies. However, there are limitations, technical limitations, and only a handful of diseases that we can accurately diagnose. So they're gradually falling out of favor except for some selected situations.
Yeah, I don't order many nerve biopsies and send them for you. And I often warn patients that if we do that, there is a very high chance that we won't be able to find the answer.
Yeah, exactly. In my experience, we can identify, okay, there are some degenerating axons here, there is some fiber loss, but it is really difficult, essentially impossible to say why this is happening.
Yeah.
So I think that's accurate.
Yeah.
Here is the histologic representation of what we just talked about. Angulated atrophic fibers, and a few of them got together, forming a small group, atrophy. And here is our special stain, dark and light fibers, but instead of checkerboard, we have now reinnervation and fiber type grouping. And here is the large group atrophy. The entire fascicles are atrophic, alternating with relatively normal ones.
All right, so what are we looking at here?
Well, this looks like a nerve to me, and I believe I'm right. We talked a lot about muscle histology and its diseases. We're not going to get into the nerve pathology that much, or any at all, pathology-wise at least. But I wanted to give you a flavor of what nerve looks like histologically. Note that muscle sections were pink and blue, and this is all dark blue and light blue and maybe some lilac. This is a nerve fascicle surrounded by perineurium, and every dark circle you see is a myelin sheath, and the light area in the middle of the myelin sheath is the axon. So all together they're called a nerve fiber. And just like in muscle, we have here endoneurium, and this is perineurium ensheathing the entire fascicle. And then there is a surrounding fibrofatty vascular connective tissue called epineurium. Note that there are small and large myelinated fibers, as well as unmyelinated fibers that we cannot see at this power, but they're just little holes if you go to high power, and they represent the unmyelinated fibers. There are, of course, capillaries, etc. So this is a special plastic embedded section of the nerve. It requires special processing and staining, and a lot of times electron microscopic examination, so these cannot be done everywhere. We are able to do nerve biopsies, although their yield is relatively low, unless you're looking for a very specific nerve disease or something like vasculitis, for instance.
Yeah.
Those can be very helpful. So we can basically differentiate axonal and myelin-related diseases based on these examinations. And that's pretty much what the nerve looks like.